Hi, hello everyone. Welcome to the Direct Supply Virtual Clinical Leadership Conference. My name is Liz Jensen, and I'm the Clinical Director here at Direct Supply. Thank you so much for joining us today. We've been looking forward to this event. Even though we are not live like we normally are, we've still been looking forward to being able to bring all of you together today for this shortened virtual event. We did modify the event this year based on your feedback, and so thank you for that. As many of you attended our virtual event last year, you'll remember that was the first time we had done an event like that. And so thank you for your feedback, and we're hoping that you're going to enjoy this shortened event this year. I know that so many of you have undergone so many changes this year. The COVID pandemic and all of the changes and the challenges related to staffing and just that continued response to the pandemic has been so difficult for so many. So we're really grateful that you're taking the time to join us today for this event. We also know that many of you have had a lot of changes, and so we're hoping that during the networking sessions today, you'll have the chance to reconnect with some old friends, maybe meet some new friends as well, and get to see some of the clinical executives, the therapy executives, nursing executives, physicians that have historically come to this event, and being able to share a little bit about what's really happening in your organization and getting a chance to spend some time together. As we were thinking about the theme for this year's event, the changes that are happening in our sector right now are so rapid, and really being able to kind of land on and focus on a topic in an event was something that we put a lot of thought into. And so this year we decided that we were really going to dig in a little bit to some of the history of research that's been done in the last couple years, kind of pre-pandemic, but some of the things that are informing our view into policy development, research that's really informing how regulators are thinking about our space as well. So we decided to go back and look at some of that. And then we're also going to take a look forward. And what are some of the fundamental technology changes that are happening? What are we learning about healthcare technology? And how we can anticipate that it might be impacting how we're delivering care in the months and years to come. So we're really pleased today to invite our two speakers, Dr. Patricia Stone, who is the director for Center for the Health Policy at Columbia University. I think you're really going to enjoy hearing from her today. And then many of you have possibly met Justin Smith before in the past. If not, you're in for a real treat. Justin is the Technology and Innovation Manager here at Direct Supply, and he's going to give us a little peek into the future with healthcare technology. I wanted to just take a moment and thank so many different individuals that have been supporting our chief nursing officers and other clinical executives in our space. Many of you have been working tirelessly behind the scenes or networking and engaging with your fellow peers. And through the Nurse Executive Council, the Senior Living Clinical Collaborative, the Nadana show that just occurred actually last week, where Sherry Dornberger invited so many of the Nurse Executive Council to come and meet. Elna, Cal Groneweg, and Margot Coons, and all of the work that they're doing at Elna. And then a special thanks to Joanne Carlin at Willis Towers Watson as well. All of these groups and more are providing really great educational content. And Gail and Karen and Julie have just done a remarkable job of staying connected with the nurse executives, and Julie and Kathy with our assisted living nurse executives as well. So thank you to all of you. We are a network of nursing leaders that are supporting each other, and it's really been great to continue to work with all of you. A special thanks to Carolyn Brown from Carolyn Brown Consulting. Carolyn helps us every year with our continuing education units, and this year we're pleased to be able to offer two for this this shortened event. And so after this event, you'll be getting a survey. We'll ask you to complete that, and then we'll send you a certificate for your CEUs. So here's our agenda for today. We will be transitioning here momentarily to an opportunity to hear Dr. Stone. Then we'll move over and listen to Justin speak about demystifying the world of healthcare technology. We are going to have some time for some networking sessions, and you'll get the chance to talk with each other. In smaller rooms, you can go back and forth between networking sessions and get a chance to see as many people as you want to during that period of time. And then we'll all come back together again for our closing and some final remarks and some insights into what comes next. So with that, I'd like to introduce to you now Mimi Gary. Mimi is the marketing manager for our health and wellness team here at Direct Supply. And she's actually coming to us live from our main campus in Milwaukee, which many of you have visited before. I'm at our Innovation Center today along with Justin. And so we've got both campuses kind of covered. If you have any questions during any of the sessions, you'll see on your screen the ability to submit questions at the bottom of that. So please feel free to do so. And if we can, we'll get to as many questions as we can, but if we can't get them all answered, we'll make sure to get those answered and get those answers back out to you after the event as well. So with that, without further ado, I'd like to turn it over to Mimi, and she's going to lead our conversation with Dr. Patricia Stone. Mimi?
Thank you, Liz. Today, it's my pleasure to welcome Dr. Pat Stone to our Clinical Leadership Conference. Dr. Stone is the Director of the Center for Health Policy at Columbia School of Nursing and the Editor-in-Chief of the American Journal of Infection Control. Dr. Stone is one of the few nurse researchers among other interdisciplinary researchers like economists, hospital epidemiologists, and health services researchers who deeply understand the complications and rigor of conducting real-world comparative and economic evaluations in the context of improving the quality of care and specifically preventing healthcare-associated infections. Dr. Stone has a long history of conducting research in this area and has been the principal investigator on many federal and foundation-supported grants. This expertise and her sustained scholarly efforts in this area have been recognized and have improved healthcare in a variety of ways. She has served on a number of important policymaking committees, including co-chairing 2 National Quality Forum technical advisory panels and service as an expert for the Massachusetts Expert Panel on Healthcare-Associated Infections and the California Health Department. Additionally, her work on the cost of healthcare-associated infections has been cited in major publications, including guidelines and a burden of illness study written by the CDC and the Health and Human Services Healthcare-Associated Infections Action Plan. These activities have contributed to the recent changes in health reporting policy, as well as the type of data that hospitals are collecting. Dr. Stone is passionate about conducting policy-relevant research and educating the next generation of nurse and interdisciplinary scientists. Without further ado, please join me in welcoming Dr. Stone.
Thank you so much, Mimi. I really appreciate that warm introduction. And I'm very excited to talk to you today about the work that I've been doing in nursing homes looking at infection prevention and control. This work is funded by the National Institute of Nursing Research, and I have no conflicts of interest. So, as you all know, nursing homes serve a very vulnerable population. There's approximately 1.6 million Americans that live in the somewhere just almost 16,000 nursing homes at any one time across the United States. 85% of these residents are elderly, 66 are men with a primary diagnosis of dementia, and about 40% have advanced illness. Pre-pandemic, the infection control deficiencies were one of the most common inspection citations by the Centers for Medicare and Medicaid Services. One of the things that we wanted to know, because all the estimates about how many infections were really old, so we used the minimum data set, the MDS, from 2006 to 2013. So that was a 2.2 and the 3.0 MDS. And we used the fourth quarter, and we estimated the infections from the MDS. And as you can see, in all years, UTIs and pneumonia were the most commonly reported infections. And based on but there was a real change between 2.3 and 3.0, as you would expect. But based on the 2013 data, we estimated that there was anywhere between 1.13 to 2.68 million infections occurring in nursing home residents annually. And this is a New York Times journal article that was published in September 11th, 2019. It was entitled "Deadly Germs, Lost Cures. Nursing homes are a breeding ground for a fatal fungus." And this shows a nursing home resident in a New York City, it's actually in the Bronx, nursing home, and she had Candidus auris, which is a very deadly, multiple drug-resistant yeast infection, and there was an outbreak of this occurring, and this is all pre-pandemic. When we look at hospital transfers caused by or with infection, we found out that a lot of the hospital transfers, from the resident transferring from the nursing home to the hospital, anywhere between 35% to 40% are caused by infections. And the way we define caused by infections is that is the primary diagnosis present on admission in the hospital record was an infection. And then we had caused with an infection, and that was that the infection wasn't necessarily the primary diagnosis, but could be any one of the 26 admitting diagnosis. And when you look at with an infection, nursing home residents transferred to a hospital with an infection, it's anywhere between 57% to almost 62% or 61% in 2017. So there are lots of nursing home residents that are being transferred to the hospital caused by or with an infection. We did another analysis. I'm sorry, the graph is a little bit blurred, but we did what we called an event time study, and we used the MDS and MedPAR, and those are the diagnosis records. And the figure shows that most of the residents are having cognitive decline. We'd expect that, and you can see this decline. This dotted line would be the continued decline if the resident was not transferred to the hospital with an infection. But when they're transferred to the hospital with an infection, there is long-term consequences related to cognitive decline. And that was published in BMC Geriatrics. So infections are a problem. Why is it such a problem in nursing homes? We know prevention is difficult due to the shared living spaces. We know that diagnosing infections in nursing home residents is difficult due to the changed pathophysiology, the compromised physical barriers, the functional impairments of the elderly, communication difficulties, and the lack of technology and access to advanced clinicians. We also know that antibiotics are over and misused, so these infections are often multiple drug resistance. Indeed, just being a resident in a nursing home makes the individual at high risk for having a multiple drug resistant organism. So one of the things we did was, in part of our study, was we went to nursing homes across the nation. We went to 10 nursing homes and interviewed 73 employees. And we conducted this qualitative research. And what we found were 5 themes that came out. One was residents' need, and that's the tension between the facility being the resident's home and the need for infection prevention and control procedures. Remember, all of this was pre-pandemic. A lot of it still is relative today, though. The roles in training, many employees, most employees involved in the infection control program had multiple other responsibilities and frequently lacked any formal training in infection prevention and control. I remember one nurse say, "It just came with the job of being the supervisor. I've had no extra training besides my nursing training." People tried to use their infection data. They were used to improve care, but there was so many variations in how each nursing home defined their infections and how they used any of their data. The people we interviewed did look for external resources, such as the CDC or their national or their local health department or state health department, or some learning collaboratives for information and support, and sometimes to their hospitals. Everybody focused on hand hygiene. Everybody knew the importance even then about washing their hands. But all infection prevention programs, while they focused on it, it was very informal. One nurse said, well, when I see a CNA coming out of a room with their gloves still on, I'll tell them that they're not following hand hygiene. There's nothing formal like in the hospitals where they have a really formal process to monitor compliance with hand hygiene protocols. So then after we did our qualitative study, then what we wanted to do was to conduct a national study. And this was our first survey. We've done 2. It was in 2014. We had over 1,000 surveys returned, but only 990 were usable. So we had a 39% response rate. And then we linked that data to the Casper data and the minimum data set data. And the results, just like in our qualitative, we can triangulate these results right here. The person in charge of the infection prevention program had multiple hats. So we also found that the citations, the CMS citations in infection control were related to the experience of the person in charge of the infection prevention program. When they were more experienced or certified, they were less citations. However, certification was very, very limited, and only less than 3% of IPs, we call person in charge and infection preventionist or an IP, were certified. And again, those that with certification had better policies in place and more recommended practices. So some of the other analysis we looked at was the use of isolation in nursing homes. And the rationale was the evidence of effectiveness of isolation or contact precautions was based on hospital settings. This is a picture of one of my doctoral students, Katie Cohen. She graduated from her with her PhD in 2016. She's now a senior policy analyst at RAND, and she had won an award for this, her dissertation. And she used MDS, which was included 96% of the nursing homes, and data from 2011 to 2013. And in that data set, she found almost 200,000 MDS assessments that said the resident had a multiple drug resistant organism. Of those nursing homes with a patient with a multiple drug resistant organism, only 31% said they used isolation. And another doctoral student, Dr. Jasmine Travis, she studied at about the same time. She's now at NYU as an assistant professor. She looked at racial and ethnic differences in the receipt of influenza and pneumococcal vaccination in the long-stay nursing home residents. All of this has been long-stay that we've been talking about. And she used the 2010 to 2013 MDS data. And in her sample, she used a sampling of these data, and she had about 100,000 residents in 742 nursing homes. And what she found that Blacks were less likely than whites to receive influenza and pneumococcal vaccinations with an adjusted odds ratio of 0.75 and 0.81 respectively. And Hispanics were more likely not to be offered pneumococcal vaccinations than whites with an adjusted odds ratio of 1.22, 22% more not likely. So health disparities are present in the nursing homes. So what's the policy impact of this, first part of our study? You know very well the 2016 CMS final rule included every nursing homes must designate an infection preventionist who's primarily responsible for the infection prevention and control program, not somebody that wears multiple hats. And the IP must sit on the Quality Assurance Performance Improvement Committee. Also, the CDC, knowing that people were not using isolation, and based on our work and other work, came up with some new enhanced barrier precautions that help the nursing home staff use contact precautions when they're doing high-risk procedures, such as changing, bathing, and changing dressings on wounds. So in 2018, we conducted a second survey. This is a copy of our survey. Maybe some of you actually participated. We had 892 responses, but we got a 50% response rate this time. And we had all of the same data in the first survey about the characteristics of the infection control program in the facility and training of the person in charge of the program, that is the IP. But we also brought in some new concepts. We brought in palliative care processes, infection management processes, and the integration of palliative care and infection management. So looking at the change of the infection control programs over time, again, this is from 2014 to 2018, all pre-pandemic. We had questions about antibiotic stewardship policies, about outbreak control policies, urinary tract prevention policies, and all of those we calculated a standardized intensity index for each one of these. We also had the same data on the infection preventionist certification and training. I'll show you the changes over time. For the antibiotic stewardship, there was significant increase in the intensity of having these policies in place from 2014, 32% up to 66, almost 66% in 2018. And CMS had said everybody should do it, so you're surprised it's not 95%. With the outbreak control policies, that was at, the intensity was like at 55%, and that went up to 68%. And the urinary tract policies, that was at about 50%, and that went up to 56%. And all of these were significant differences. Because outbreak is so important in the pandemic, I'm going to drill down just on this one group of policies, where we saw there was no difference in cohorting infected residents, and that occurred about, less than 70% of the time between the two times, and that was not different. But all the rest of these policies were, that is, having a policy about being able to confine a resident to their room if they have infections, the use of rapid diagnostic methods for case detection, closing the facility to new admissions, instructing infected staff to stay home, and administering prophylaxis, as well as quarantining units. So you can see that these, all of these except for the cohorting, there was significant improvement in the nursing homes having these policies. Thank goodness we had some improvement. When we look at the infection preventionist training over time, so it was 2.65, less than 3% in 2014. It went up, to over 7% in 2018. Still not that high, but better. The training occurred, using state or local training courses with a certificate. Some used a national or local training course through a professional society like NAMDA or the Association of Professionals of Infection Control. Then there was other, but still 44% of the nursing homes that we surveyed, still the person in control had no specific infection control training. Now that was down from 64%, so that's better. We're moving in the right direction, but it's clearly not good enough. So when we looked at the changes in infection prevention over time, it really, there was a change over time, on all of these, and the time made a difference. But it also, and this is a multivariate analysis, but it was also the education and the training of the infection preventionists made a difference in having these policies in place. And when you had a trained, certified infection preventionist with a certificate or training, this all made a difference. So now I want to talk a little bit about that integration of infection management and palliative care in nursing homes. So in the survey, we could only use 892 of our surveys here, but this was weighted to represent a full sample of 15,000 nursing homes. We asked about infection management and palliative care policies, and that was how often does your facility elicit preferences for terminally ill patients in the following situations: when a resident condition changes, such as fever, following an event such as aspiration, during care plan meetings, or on admission. And you could see that asking about these did not occur very frequently on admission or during care plans. It was only, when there was a fever or an event such as aspiration did they happen most always. And then for suspected infection near end of life, how often does your facility include the residents or proxies in treatment decisions for suspected infections near end of life? Consider residents' goals of care and management of the infection. Adhere to standard infection control policies such as isolation, and give antibiotics. And here a lower value obviously is better, because you shouldn't be giving antibiotics at the end of life if there's nothing they can do for the person. It just increases antibiotic misuse in multiple drug-resistant organisms. So, almost always, 75% of the time, they included the resident or proxies in the treatment decisions. Their goals of care did not happen quite as much. And antibiotics were, still sometimes given, the biggest one being 52% was sometimes. So lots of room for improvement. And then we had these vignettes, and this was the vignette. Mrs. Davis has been in your facility for 4 months. On admission, she was ambulatory and needed total assistance with feeding. She was admitted with advanced heart disease, osteoporosis, a right hip fracture, and Alzheimer's. She takes oxycodone, 10 milligrams every 6 hours for pain. In the past month, you notice she is eating less, has lost 10 pounds, and coughs when drinking. She no longer recognizes her family. Scenario 1. Over the past 24 hours, she has developed a fever, cough, and shortness of breath, and clinical exams suggested an aspiration pneumonia. In your facility, how likely is that she would have a do not resuscitate order, a do not hospitalize order, a do not administer antibiotics order, would already have orders reflecting palliative comfort measures only? The proxy for Mrs. Davis would be asked how to manage the suspected infections, and the medical providers would decide how to manage the infections without asking the proxy. Or she would be sent to the hospital, And all those not likely, somewhat likely, very likely. Then there was scenario 2. Over the past 24 hours, Mrs. Davis appears more confused, and her family mentions to the nurse that her urine looks dark and asks if she has a urinary tract infection. She has not developed a fever. In your facility, how likely is it that a straight catheter would be used to collect a urine sample? She would be treated with antibiotics. She would be treated only with measures such as analgesics and oxygen to reduce discomfort. That is, no antibiotics. So those are our vignettes that we used. And from those two things, we came up with 3 integration subscales. And one was involvement, and we used consider goals of care in managing suspected infections, include resident proxies and treatment decisions. And then for advanced care planning, we had would have a do not resuscitate order, would have a do not hospitalize order, would have a do not administer antimicrobials order, and would have orders reflecting palliative or comfort care measures only. And proxy would be asked how to manage the suspected infections. And then the 3rd subscale was routine practices, and that was a subscale using the straight catheter would be used to collect the urine sample, and she would be treated with antimicrobials. And you can see that generally these subscales were not used all that much. The mean here was 73 points. The mean for the advanced care planning was 34 points, and the mean here for routine practices was 31.4. All the subscales, this is a Cronbach's alpha, were pretty internally valid. And all of these integration subscales had small positive correlations with infection management and palliative care, suggesting that they're different than infection management or palliative care alone, so that the integration of infection management and palliative care at end of life is really sort of a new concept. And I think something that we understand needs to be done, especially in this ongoing pandemic time. There were few associations between regional, state, or nursing home characteristics, so we really don't understand what nursing homes are doing this best yet. Just briefly, as of July 15th, more than 184,000 residents and staff have died of COVID-19. In Johns Hopkins Medical System, 21% of COVID cases came from nursing homes, 50% of the deaths. Linking COVID cases with nursing home data using the CDC COVID cases, we found nursing homes in which there's greater percentage of Black had many more cases and many more deaths. COVID-19 and nursing home, there's health disparities that have come out of this, and it's just been horrible to live through, and you've lived through it. I don't need to say more about that. What I want to talk about is the policy impact. CMS last summer had to put together a commission on coronavirus and safety and quality in nursing homes. And they had 27 recommendations about improving infection prevention and control, including having a full-time trained infection preventionist. And that was something I thought our research showed that that's really important to do. Couldn't yet say that, palliative care and integration was needed, but I've talked to many clinicians, and they said if you weren't up on your advanced care planning at that time, you're really behind the 8 ball before you even had an outbreak. And I think thinking about infection prevention and infection management at end of life is something that COVID's shown a light on that we need to be doing. There's also a review of 21 COVID-19 nursing home guidance documents around the world, and it was reported that the focus mainly was just based on infection prevention and control. That's good, but only a few sentences on palliative care. So I think we have a place where we can really make a difference if we think about appropriately providing the tailored care based on the preferences of the resident and their family. And we should be doing that for these people. So in discussion, infections occur frequently in nursing home residents, and that was even pre-pandemic, frequently result in hospitalizations, and they're having long-term consequences for the resident. Infection management is suboptimal, and treatments are often burdensome and inconsistent with palliative care goals. Infection prevention and control in nursing home is evolving very quickly with COVID-19. Indeed, there are many recommendations for having trained certified infection preventionists. The CDC now recommends that every nursing home with 100 beds or those with mechanical ventilation or dialysis have a trained infection preventionist. California just regulated that, or legislated that nursing homes have an trained infection preventionist, and that's going to be starting January 2022. The legislation was passed not long ago. Okay, so I have to thank my funder, which is the National Institute of Nursing Research. They were actually in the midst of the pandemic, happy that we were doing the research too. And obviously, we need to thank a fabulous interdisciplinary team. Research is never about one person. It's a team sport. And of course, I'd be remiss if we didn't thank all the nurses who participated in our research, conducted our interviews, agreed to be part of our interviews, as well as filled out our survey. So I think now it's time for questions.
Yeah, thank you so much, Dr. Stone, for that great presentation. We have a few minutes left, and we can go through some of the questions that we received from the audience. We won't get through all of them, but we can definitely take a good start. So let's start with some lessons learned. Given what you've seen in acute care and how the role of infection preventionists has developed and evolved, what are some of the lessons learned for policymakers and providers that can help them realize the benefits of investing in IPs in long-term care?
Yeah, great question. Whoever thought of that question. I've been doing research in infection prevention and control since the turn of the century. And what I saw happen was that the infection control department in hospitals, it was legislated that they had to start, the hospitals had to start reporting their healthcare associated infections, and the infection preventionist profession grew. They got more confidence, and that's in hospitals, and they became multidisciplinary teams. Now, the multidisciplinary teams for nursing homes, I think that's going to happen, that this isn't just one person alone. It should be, they should be talking with their hospital director, and maybe in partnership with a local hospital with other infection preventionists. They also, I think, as this profession grows, and I believe that long-term care infection preventionists is a profession that's growing, as they're going to get the education, because just being a nurse is not enough. Not all infection preventionists are nurses. They could be a microbiologist, but the background training is not enough. And you need the support of a community. And, like these Association Professionals in Infection Control, or APIC, they have local chapters across, and I imagine that they're going to be starting local chapters for long-term care IPs. And so there'll be cross-fertilization, and people will be able to learn from each other as this develops.
So important to collaborate with all of the disciplines involved in care practice, absolutely. In your research, what were the specific areas of infection prevention and control practices and processes in long-term care where IPs had the most impact? Maybe education or surveillance, any other areas?
Well, I think, we looked at did they have the antibiotic stewardship programs in place? Were the urinary tract infections, the recommended practices to prevent urinary tract infections in place, and the outbreak policies? The IP really impacted that. But we also, some of the things that I did not get to present today, because it has been a long time of research going on, was that there's less infections occurring, and that's going to be due to education of the other staff. And we got to remember that training is not just for the nurses, it's not just for the physicians, it's not just for the visitors, it's not for the nurses' aides or the environmental services or the people that are bringing the dining room people. It's for every single person that enters. Infection prevention and control is everybody's responsibility, and everybody needs to be trained. We know that a little bit more with the pandemic now, but it's so important.
Yeah, absolutely. I think we have time for one more question here, and it's a lengthy one. So bear with me while I read this back. According to data published by NIC, SNFs and memory care centers experienced the highest mortality rate of long-term care settings during the pandemic. Physical environment and workforce shortages pose significant challenges in these environments. Although your research has largely been conducted in nursing homes, in your opinion, where should policymakers and regulators focus their attention and resources that can make the biggest impact in both federally regulated nursing homes and state-regulated assisted living?
Yeah, very, very important question. We need to not forget about assisted living. And indeed, although I have not studied assisted living, we are doing some similar work in home health care at this point. There's such a need for all of it. And we really need to, in all of these settings, improve infection prevention and control. It's especially once we get post-pandemic, and we will get there. I'm not sure when. I thought we were almost there, but Delta variant came up. But when we get there, we got to remember that infections were problematic. Multiple drug-resistant infections. Remember the woman that had the Candida auris, and it was an outbreak, and it went from the nursing home to the hospital. These things spread in a community. So all of these settings are very important. And I think I think the CDC has known this for a long time. I think, you know, the national policymakers and regulators are just starting to understand that, and that it really takes a community, and we have to be in all the settings to be focused on best practices.
Excellent insights. Well, that brings us to our time for this session today. I'd like to thank you again, Dr. Stone, on behalf of the Clinical Leadership Conference and our attendees for sharing your work and thoughts on infection prevention.
You're very welcome. Thank you.
Liz, back to you for our next presenter.
Mimi, thank you so much. And Dr. Stone, thank you for taking the time to come and meet with us today and sharing your work and the research that you've done. I think, you know, as I listen to that, one of the takeaways for me is just, it's really helpful to not lose sight of the fundamentals that we need to stay focused on advocating for the funding support for infection prevention staff and training, and in that ongoing investment in education, not only in infection prevention and control, but also in the palliative care planning process, both in nursing homes and assisted living communities, and how critical that really is. So thank you so much. Great session. At this time, I'd like to now check in with Justin Smith from our Direct Supply Innovation and Technology Center. Justin is an engineer and manager of the Innovation and Technology Group at the Direct Supply Innovation and Technology Center at MSOE. Justin started his career in product development at GE Healthcare, working in design, usability, and validation of, validation of new medical devices. Justin leads the Innovation and Advanced Technologies program, including a focus on emerging healthcare tech, including medical IoT, the Internet of Things, artificial intelligence or AI, computer vision and voice control applications within the industry. He also works with technology startups across the US and overseas to develop and test their products and move them from an alpha stage into beta pilots with healthcare customers. Justin holds a Bachelor's of Science degree in Electrical and Computer Engineering from Marquette University. And I am pleased to call him a colleague and a friend. And he's someone as an engineer that's, for me as a nurse, it's taught me a lot to think about and learn about how this changing world of healthcare technology is so critical for clinicians to understand because it's becoming more and more a part of our world and our day all the time. So Justin, thank you so much for joining us and welcome.
Absolutely. Thanks, Liz. And welcome everyone. Glad you could join us today. Over the next 25 minutes or so, my goal is really to walk through a little bit of my view of some of the kind of emerging technologies that we're seeing enter the space, especially around the infection control world. We've just heard a lot of great insights about kind of what's happening today. And so my goal is to give you a little more information. If you have questions throughout this, feel free to add them in chat. We're going to have a little Q&A time at the end as well that we'll try to pull in as many questions as we can. So Liz gave the background. I'll tell you, this was pre-pandemic, professional photo. Post-pandemic, full beard. It's been trimmed down a little bit now. But even on my vations, I'm still kind of nerdy. So I took some time off, went down to Cape Canaveral, really got into the whole science piece. So My goal with any of the solutions that we're looking at is really to kind of dig into the science piece, to understand how they operate, to understand the impact that they can have, and I hope to give you some insights into that today. So how do we define the problems? The hierarchy of controls is not going to be anything new to this group, and I think especially as we've just heard from Dr. Stone, these are the areas that we start looking at as we're trying to really focus on impacting infections and infection prevention within the community. And so as I look at it from an engineer's perspective, I'm trying to think of, what are the things that we can do to impact kind of each and every one of these levels. So I think over the last, year and a half now, there's been more and more push to, identify some maybe non-standard solutions to some of these things as supply chain becomes an issue, and as other pieces, start popping up. We try to look at how we can actually impact these things. So one of the things that I think I really like to do, and Liz and I have spent a ton of time on this, is this whole idea of understanding the resident journey. If any of you have been to the tech center here in Milwaukee, you've probably seen this. We have a gigantic printed version of this that's in our lab. The real version is actually covered with sticky notes from customers who have been able to put their view into this, and here's things that we may have forgotten, or here's things that we should be thinking of as we move through this. But the whole idea with the resident journey map is, I think, historically from an engineering perspective, there's a lot of times that we look at the singular problem and we try to find a solution for that exact problem, and a lot of times we miss out on the full picture. And so by pulling this resident journey map together, and this was Liz's brainchild, so I give her total credit for this. By pulling this resident journey map together, we're able to understand and look at it across kind of the changing dynamic of a resident moving into a community and what they're kind of dealing with. So we have kind of the phases of the resident's time, within a community. The larger version of this also has, who are all the people that are actually interacting with that resident. So it could be from the clinical side, it could be from the operational side, it could be from the environmental services side. And so once we get that 30,000 foot view, we can really start to understand these are the areas that we can have impact. And maybe we can have a larger impact than just that one thing we were looking at. Maybe we can actually have a larger impact across the board. And so this is a great way to kind of step back from the problem, understand kind of where you are in the journey, before kind of getting right into solutioning and finding those new solutions and new products. So how do we actually view the solutions? Honestly, right now, the focus is on filling the void. I grabbed a couple of headlines here. We know that staffing is probably the number one issue that our customers are seeing right now. We're seeing it across, honestly, not just the clinical side, but we're seeing it across almost every role within a community. And so as we look at technologies to come in, we're keeping that in mind of, not just are there kind of raised expectations within the community, but in many places there's less people to actually do the work. And so how can we help to fill that void and keep these communities safe? So the thought there is, instead of replacing, let's optimize. I think a lot of people, when they hear that we're looking at solutions and technology and everything else, the easy kind of first view is, oh, well, they're just looking to replace people. Well, that's certainly not our goal. If anything, our goal is really we always use the term, give the Iron Man suit to the people that are within a facility in the community. So give them capabilities that they may not have today. Give them the ability to, have a larger impact with the people that they do have. So what that could look like is this whole idea of kind of shifting work. So that could be shifting, non-value added work off of clinical staff and to others within the community. At the bottom, it could be, automating some of that work to just get it off of the plate completely. Also looking at workflow redesign, fewer staff or fewer steps, dedicated staff. So it's not always technology. From my standpoint, I love the technology piece of it, but sometimes it's actually just looking at, how can we make the workflow more efficient, more effective? And so that's certainly a new way for a lot of us to think about it, of just, going in and observing and kind of going from there. So hopefully if you've been at any of our CLCs historically, you've seen this kind of thought process, and this is kind of our innovation process. It's really the ideate, incubate, realize. And so as we talk through this, I always say that it's a funnel and maybe a filter. And so at the very top of the funnel, you have ideate, which is all of these ideas, all these things that are out there, all these, maybe great ideas, maybe mediocre ideas, but they all kind of come together at one point. So then what we do is we kind of filter those down to the ones that we think, all right, these are the ones that are actually going to have an impact. And we move them to that incubate stage. This is where we're really working with our customers. We're doing internal tests. We're doing beta and pilot tests out in the real world to start kind of confirming that our assumptions about these solutions are true. Is the ROI correct? Is the value that they're claiming what we're actually seeing? So we go through that incubation process. And again, we filter. So now we're to realize. And realize is really this point of we filtered. These are kind of those final few things that we think are going to have that impact, and we're ready to kind of bring out to a larger group. There's still testing. There's still going to be iteration that happens, but we think it's ready to actually go out there and have some impact. So this is the kind of high level process that we focus on. A perfect example of this, and this is not meant to be a commercial, but DS Smart, which is our connected vital signs solution, this ultimately came out of this conference. So, a few years ago, we talked to clinical leaders and we said, what are the areas that you're spending the most time? What are the things that aren't necessarily value added? And one of the things we got was, obviously that process of collecting vitals. It's strife for errors if we're doing it manually. The whole process of going from a vital signs monitor to typing information into an EMR. Maybe it's something that's wall mounted. Maybe it's putting something on a piece of paper. That whole process could probably be improved. And so, we took the feedback from the people in this group and we basically started to iterate. So we took that idea and we started to evolve it. We started to put paper prototypes together. We came back to members of this group and said, all right, are we on the right track? We got some confirmation and we got critiques, and all of that came together to ultimately, really a couple of years after it was brought up, for us to be able to bring this solution out. And again, the focus was, if we can identify a better process and we can potentially bring some technology in, we think we can save time. And so this whole idea of being able to increase the accuracy of collecting vitals, make it 40% faster, reduce the number of duplicate measurements that need to be taken. Those are all things that we were looking at, but it kind of talks through how that process could work. So the changing environments of aging, we certainly heard a lot with the previous speaker about how expectations are changing. And what I want to do is give you some insights into how we, or at least how I see that actually happening. So one of the things that Liz and I have actually been talking about a lot lately is this whole idea of the building as a caregiver. I think over the last, I won't say few years, but over the last many years, we've gone from the clinician themselves being kind of the only person who is identified as a caregiver within a community to all the support staff, all the way down to operational folks, because the heating and HVAC system, having consistent power, having consistent communication, all become part of the ability to deliver care as effectively as possible. And so as we're moving forward, we're seeing more and more of these things come out about the building itself being kind of part of that care team. Some things that stand out for me in this one, specifically to our conversation we're having now, air quality has certainly become, air quality has gone from something that was kind of important in a lot of communities to maybe the top important thing within a lot of communities over the last year and a half. And so, how are we not only improving the air quality, but how are we monitoring it in real time? How do we understand as that air quality is changing over time? When we look at like real-time location, how do we know where the staff, where the equipment, where the residents are within a building at any given time? And maybe this is trying to handle infection control and understanding who's spending time, with whom within the building. But it also gives us insights into how effective, and efficient we're using our time. We look at things like wearables. That's something where I think we're starting to see those become a more common thing. Being able to pull information for a resident or even staff members at any given point in time, and this move from episodic data for residents to really continuous monitoring. And so all of these pieces are starting to come together where it's not just the ability of the care team and one person to walk in and talk to a resident and understanding what's going on with them, but all of a sudden all of these other factors that come into play that help to really drive that care delivery model. And so I'm going to go through kind of a handful of examples here, just to kind of give you some of my thoughts on some of these things that we're seeing coming out, and hopefully give you a little more insight into how we kind of vet some of these technologies. So starting on the left side, needlepoint bipolar ionization. This is ultimately an air cleansing solution. And so this is something that I remember very clearly. Liz and I were sitting in an airport, sharing a beer, not sharing a beer, but having beers, and talking about this technology that we had started to see. And the whole premise behind it was that it can clean the air, but also reduce some of your energy costs. And at the time, this is well before the pandemic hit, the thought was, we don't know if people are going to invest in the air cleansing piece, but there's probably a lot of interest in the power savings. Well, cut to a year and a half ago, that completely flipped on its head, and all of a sudden air quality was one of the top issues. And so this is a system that I will break it down as simply as I can. The whole idea is that there's a device that goes into your air system. It goes after the kind of filters that are there, so it gets relatively clean air, and it injects these negative and positive ions into the airstream. And so the whole thought is that these ions are ultimately tiny magnets. And so they are going to be attracted to any kind of particulate matter or other things that are within that airstream. So that could be things like dust, or that could be microscopic things like odor molecules or viruses that are actually floating through the air. And through this kind of magnetic attraction, you ultimately kind of clump around those things. Typically what we'll see is that deprives them of oxygen or other things that, especially from the viral side, they may actually need, or strips away their ability to replicate. And ultimately what we see is it also makes filters, and whether that's air filters or even masks or other things, more effective, because now these clumps at the kind of microscopic level are larger and can be filtered out more easily. So, this is a technology that sounds great, but on our side, we had to go and actually test this out. So this started with us putting it in place in our own building. So the building that Liz and I are sitting in now, every one of the spaces within this building has this technology. We've done real-time testing across all of our buildings, across customer sites as well, to validate the technology, even pulling in our data science group and looking at communities that had installed this technologies and communities that hadn't, and the impact that it had on infection rates and in all the way to deaths, so that we could feel confident through that data that we're putting the right solution out to our customers. So that's one that I think is awesome, and we're going to see more and more focus on kind of air quality moving forward. Some other things, thermal screening. So this is one that kind of came out early as we started looking at the ability to identify people who potentially had infections within the building. And so this whole idea of screening at the entry points, and how do we get away from having someone at the front with an infrared thermometer scanning every person that comes in. And so these are technologies that we looked at that ultimately came out of Asia, because Asia's been worried about this for a long time, prior to this pandemic. So that's the technology we looked at. UVC robotics, being the engineer, robotics is always cool in my mind. But this is an interesting one where we think about, we have kind of UV towers today, and the whole thought process is that you can push them, you find an empty space, you push them into the space, you hit a button, you let it run for 15 or 20 minutes. You move it around maybe once, one or two more times, hit the button again, go through that cycle, and it kind of hits every point within the room. And you start with this kind of new, kind of fresh area. So this whole idea behind UVC robotics is, can we actually do some of that process automatically? So this is a solution that we're looking at that I don't think the people who are behind it like me saying it, but it's kind of like a UV robot or a UV tower sitting on a Roomba. So the whole idea is that you can ultimately move it into a space. You can, make sure the space is empty. You hit the button, and this automatically tracks the outside wall of the room. And so it can go around beds and furniture and everything else. And because the light is always moving within the space, you're hitting all the different points within that room, and you can get a higher effective kill rate in a shorter amount of time. And so you can put this in place, you can hit the button, and in about 10 to 15 minutes, it is done. It'll send notification to your phone, let you know that it's done. And it also has a whole bunch of safety features to make sure that if anyone opens the door or if anyone comes into the room, it automatically shuts down. So safety is certainly in mind as well. And this is one where, we saw this used in a hotel room where we actually put UV reactive Post-its all over the room to understand how much of a dose was actually happening throughout the room as this went through. It was really cool to see kind of how well these types of solutions work. So I think we're going to see more of these types of things that help offset some of that labor play, but provide additional value. Passive monitoring. So this is one that if you've heard me talk at CLCs prior, that I'm pretty passionate about. This is one where, again, that ability to know what's happening for a resident, somewhat around the clock, I think is going to be a more important factor. So starting with the lower left, we start with some of the solutions that are out today. So this is specifically is some images from SafelyU. SafelyU is a machine vision based falls monitoring solution. And so the whole idea behind this is that you have a camera sitting in the corner of the room. There's no live feed that someone can kind of watch in real time, but there's a computer sitting behind the scenes that is ultimately looking to understand when someone makes a move to the ground. And maybe that's a fall, but maybe that's also someone doing that on purpose, letting themselves down out of a chair or out of the bed onto the floor. And so what we're seeing is that, especially in places like memory care, 90+% of falls are ultimately unwitnessed. And so what ends up happening is you have a clinician or some other staff member walk into a room and find a resident on the floor. No idea how they got there. No information about injury or anything else. And so with this solution, you can ultimately turn that around and provide this insight that's never been there before. This information that we haven't had access to say, here's exactly what happened. The resident let themselves down on the floor on their butt. They scooted across the room to get to the television or get to something else. And our default today may be, we don't know what happened. We're going to send them to the ER. We don't know if they hit their head. We don't know what else happened. We're gonna kind of play devil's advocate, and we're gonna send them out. Well, with this solution, what we've been able to find is, the early things are things like reducing ER visits by 70%, reducing falls by about 40% by being able to review after the fact what happened for that resident. I think the coolest information that we've gotten just recently is the fact that we can actually improve occupancy. So we can increase length of stay by anywhere from 150 to 200% by having this solution in. So by getting ahead of issues, by not having to send those residents out, by not risking their own health and safety, we're able to keep them in place for longer. The other one on this one is ultra wideband radar. I've talked about this one before, but this whole idea of, we talk about the smart building and the building as a caregiver, but this whole idea of having sensors within the living space that maybe cameras are not acceptable. Maybe cameras are still a question mark for your community, but having these sensors that could be within the walls, could be just in the ceiling, and know what's happening within that space. And so we're doing testing on this one. I'm hoping that it's going to be ready for prime time pretty soon here. But the ability to understand, where people are within a space. Are they sitting, standing, on the floor? And then even that ability to pull some of that vitals information. So being able to pull vital signs information around heart rate and breathing rate, looking for things like sleep apnea, and understanding, how is breathing rate changing overnight, and with motion and everything else. And so while this may not quite be there yet, we're in the testing phase, and I think this is something that we're going to see more and more of, that allows us to know what's happening around the clock and allows us to be able to respond when something happens in near real time, instead of just kind of hoping that we're there, or hoping that maybe we're taking vitals at the right point to see some changing condition. So very, very bullish on this one. The final group, because I have to have toilets in apparently all my presentations that I do recently, is really around community health and this whole idea of wastewater epidemiology. And so on the left side, you'll see BioBot. BioBot is ultimately a company that we are actively testing with right now. And it's the whole idea of basically being able to identify shed viral load within the wastewater of a community. And so by putting sensors in place and by being able to do some near real-time testing, we're able to see if there's a virus kind of making its way through a community, and we can see that kind of shed RNA of a virus through this testing. So one of the things we're trying to figure out is how can we get ahead of these viruses? And maybe, full-blown prevention is tough, but how can we know when something's actually happening within a building? And how can we know early? So how can we identify it before all of a sudden, a quarter of our population is showing symptoms of infection? How do we know when it's just a handful of people that aren't even showing signs yet? And so the whole idea with this is you can test it at a community level. You can understand like how much load is there to say that, all right, here's where we think here's where we think that virus is within its life cycle. We think it's still very early. We also think that it's maybe 5% of the population that's affected. Let's go dig in and see if we can get ahead of this and prevent maybe further infection from happening, or get people the care that they need earlier in the process. So that's kind of at a macro level, and we see communities that are doing this, for entire cities. There's a couple of websites that I frequent that are focusing on this in this Milwaukee area. And they're testing it at the wastewater plants, and we can see actual infection rates through testing, and infection rates through this kind of wastewater epidemiology, and we can see that they're tracking together. So we know that it's pretty accurate. So the data is super helpful in this. Toy Labs, which is the glowing toilet on the right, is a startup that's still pretty early. But is really that whole idea of how do we bring that BioBot idea down to an individual room or an individual unit, living unit level. And so I always have to preface this with, it sounds a little weird to start, but bear with me. There's a machine vision camera that is ultimately built into the toilet seat, in the smart toilet seat. And so that camera is ultimately looking down into the bowl of the toilet and is doing real-time examination of waste. And so what it's doing today is it's looking for establishing a baseline for that resident and looking for changes that occur over time. So if it's looking at urine, it's looking at color, it's looking at clarity, it's looking for signs of blood, things like that, to be able to call out right away when there's some change in condition that will happen for that resident. It's doing the same for fecal samples. Where we're seeing this technology wanting to go is the point of being able to do true real-time analysis, do volumetric analysis, and even some of the kind of chemical analysis of what's happening for a resident at the toilet, at the source, so that we can identify when something is happening very early in the process and get care to that resident before something escalates and before we have to get them outside of the walls of the community. And so, the whole goal with these is just identification and getting to the point where we can respond earlier. And these are a couple of things that we're looking at that we think kind of fit that groove. And we're going to be doing some testing with them and hopefully bringing some of these forward and helping our customers. So how do I learn more about this stuff? My job is this, and so I get this kind of 24/7. But for folks that are on the call or others, how do you learn more about these types of technologies? So there's a few resources that are out there that I think are great. Leading Age has the CAST group. I'm actually a member of the CAST group. And really what it is it's a group that focuses on these kind of emerging technologies, and maybe a little further kind of down the development spectrum of ready for prime time. But focusing on those and putting some tools in place that help people to understand what technologies are out there, and even the kind of decision matrix of what technology should I focus on. So there's a bunch of different tools that are actually available on the Leading Age site, and more, we're bringing out more all the time to help kind of through that thought process. One that I actually really like, and I've talked to Karen a couple of times, is the Gerin Technologist, which is a great title. But Karen is ultimately out of Israel, and she's doing a lot of this research on some emerging technologies. She's kind of keeping a little bit of her finger on the pulse. She's an awesome resource that I've talked to before. I look at her blog to see kind of what types of things she's looking at. There's so many people that are focusing on new solutions for seniors that we kind of have to have the feelers out everywhere to understand kind of where technology is coming from, where new solutions are coming from, because it's a lot to keep on top of. And so there's a handful of folks that we stay connected with to understand, all right, what are you seeing? What's new that we need to be looking at? And the final one I'll throw out there is honestly myself. So if you have questions about emerging technologies, if there's problems that you're facing that you want insights around, we have a lot of customers that have startups that are knocking on their front door and saying, hey, I've got a great solution. We'd love to test it in your building. We have a lot of customers that tell them to come talk to us. Say, hey, go talk to the folks at the Technology Center in Milwaukee. Let them vet you. And based off that, maybe we'll talk. So, feel free to shoot me an email. I'm open to any conversations we can have about this stuff, and more than happy to dive in and give you some insights that I have from the work that we've done so far, or to look at brand new things that are out there as well. So with that, I'm going to open it up for questions. I think my prestigious host Liz is going to hop back in here, and we'll kind of go through some questions.
Sounds good, Justin. Thank you. As I was listening and thinking about how many different things are being developed and brought to the forefront, I think today, and all of the things we didn't talk about then too, right? Like the changes in some of the advances in wound care technology, for instance, and advances in resident engagement and telehealth, and there's just, the list goes on. So I think being able to be aware of what are some of those newer things that are coming our way, so that we can be as prepared as possible as clinicians when it comes time, when we're being asked to be reviewing these as well.
Yeah,
let's see, we've got a few questions. Hold on just a second. Let me go in here and take a look real quick. Our first question is, let's see, in your opinion, that's always a bad thing, is when somebody's going to ask you your opinion. Sorry. In your opinion, what challenges What challenges technology developers the most when designing solutions for the long-term care space?
Yep. So, I mean, the immediate things that pop to mind are, I think there's a lot of people that go into the solutioning process with the right mentality. They're trying to help people, but they don't necessarily understand the environment that they're going into. So I think we see a lot of people that don't understand the fundamental difference between long-term care and acute, both from a population standpoint as well as a pricing standpoint, a capability standpoint, who is interacting with residents. So I think, one of the biggest issues we see is just there's a general lack of knowledge around the industry. And so when we're looking at startups and when we're working with groups that are early on, that's something we really try to focus on. We try to focus on, all right, well, how well do you actually understand the space that you're trying to go into? And sometimes the answer is not at all, and it shows in the solution that they have. But sometimes there's groups that have a great background. Safely U is one that I use as an example here all the time, which is there's a great backstory there of, bringing this solution to market because there was a family history of dementia and seeing the impact that it had on grandparents and potentially parents, and wanting to bring a solution to market specifically for those residents and for those communities. So a ton of research went into understanding the community. There's also just good ideas that we have to help. And that's where I think we use our relationship with the people on this call to say, all right, we need to educate some people. And who are the people that we can bring onto the call, whether clinicians or otherwise, to help educate on, hey, it's a great idea, but there's some tweaks we have to make between now and the time that it's actually ready for market. And so those are the ones that I think stand out the most for me.
Mm-hmm. Yeah, it's such a challenge, isn't it? I mean, I think I think about accepting a phone call, for instance, from a startup company that wants to come in and do testing and wants to, to set up a pilot or do some additional testing. And that can just be so time consuming, I think, sometimes for providers. And, especially in the middle of like a pandemic when we're dealing with, everything that we're dealing with right now too. So being able to find ways to say yes, I think is always hard. However, is also important because that's how they learn and that's where that information comes from. So,
and I was going to say, I think now is the time to innovate, right? Mm-hmm. So, I mean, we innovate when we're in times of strife and stress. And so we've seen, even though people are stressed out and we understand that things are tough and, we thought we were at the end of this and it seems like we might not be, this is the time to think about, what are those problems that we need help with? And even though things are busy, how can we bring in some of these solutions and help us moving forward?
Yeah, for sure. I mean, I think, one of the things that's, I think, interesting too, from a clinical perspective is we're often on the back end of receiving technology that's been designed. And as a result, then may have to adapt our workflows or we end up with workarounds. And there's actually, good research that shows that the amount of workarounds that have occurred in long-term care in particular with the rollout of electronic health records over the last, 10 to 15 years actually creates less efficiencies then. And so I think the more we can get clinicians involved on the front end, or if we can find ways to be involved with developers on the front end, the more important it is to being able to develop and have, good products that are coming out for our staff to use ultimately.
Yeah, totally agree.
Good. All right. We have another question. Let's see. What should clinicians be wary of when evaluating technology design and technology claims? This is a good one because I often ask myself this question too, is, what should we be looking for as clinicians?
Yep. So I can tell you from my standpoint, I'm wary of everything at this point. Honestly, I think that, some of the first things that I look at is I'm looking at a new solution is show me the data. So there's a lot of solutions that have these ROIs and these impact statements of, we're going to do all of these things. We're going to make life better. We're going to reduce the time to do X, Y, and Z. One of the first questions that I ask is, do you have the data to back that up? Or is it just your guess or your goal to get to that point? And so I always ask for the data. Sometimes it's super early and it's just a handful of data points from maybe an individual site or some internal testing, but at least it starts to guide me in the direction. There's certainly other solutions out there that are, hey, we've been in a dozen different communities across the US, different care levels, and here's all the information we have. Very rarely, I think, do we see things early that have that amount of information. But I think that's something that you should be asking for. How many sites are you at today? What type of information are you seeing? I think the other things that I would call out is, there's this desire, I think, to understand, like, how much do they understand the workflow? And to the point that we just talked about, what does it look like to roll this thing out? Is it something that we have to change all of our processes and it's going to take us weeks or months to put in place? Excuse me. Or is it something that actually understands how we deliver care, and we can integrate it really quickly and roll something out and start seeing that value right away? Mm-hmm. And so I think those are pieces that I certainly keep an eye on, as well as just understanding if there's others within the community that you can talk to. So I always love, like, these types of events of getting people together and saying, all right, what have you tested in your community? Great. Like, was it good? Was it bad? What can I learn from other people that are doing the same thing? And again, reach out to us. Whether or not it's a solution that we are, actively providing for our customers, or it's just something that we've seen out there, I think we will give you an honest opinion on a technology. There's a lot of great stuff that we don't work directly with, but we totally believe in what they're doing, and we've seen the data, and we know that it's real. So we're more than willing to give you those insights, hopefully as a trusted friend when you need them.
That's great. I just another question I was thinking about as you were just sharing those thoughts. Can you talk a little bit about, let's see how I want to question that. This is my question now.
Yeah.
I'm gonna throw this one out.
Bring it on.
Can you talk a little bit about the difference between the clinical data that we might get out of a wearable device, for instance, versus the things that you and I talk a lot about and that I'm really a fan of are more of these passive monitoring types of technologies that take some of that burden of workload off of a clinician. However, can you talk about the difference in the kind of information that we could expect as clinicians to get out of these devices, and
Sure.
how we think about the quality, I guess, of those of that information, like a passive monitoring versus the quality out of a wearable type of a device?
Yep. Yeah. So I mean, I think as it stands today, I was talking about this with somebody the other day of the whole idea of kind of wearables versus this sensors in the walls type thing. And so, I think where it stands today is wearables are becoming more and more common, not just within the healthcare space, but I think there's probably a lot of people that have some version of it, even at home. And so I think what we're seeing is that wearables are a great solution today. And maybe great might be a little much. They're a very good solution today. And they're getting better. So one of the largest issues that we see around wearables is this whole idea of battery life being an issue. So maybe I'm only getting 8 hours worth of information a day on what's happening for a resident. Little things like it has to be put on. So there's additional overhead of changing behaviors. So making sure that wearable is put on first thing in the morning, that it's charged overnight. So there's additional steps that kind of have to happen both on the caregiver standpoint as well as the resident standpoint to get that information. But once it's on, I think you get relatively good information. From the passive monitoring standpoint, that's something where the goal is not to have to change behavior. So I have some sensor that's in my living space. I don't change my behavior. I go about my day as I always would, and it's ultimately monitoring me throughout 24 hours a day as long as I'm in that space. And both of these are going to provide information. I think the difference that's there today is the fact that with wearables, I know exactly, I tie this to a person. I know who it's on. I know that information is theirs. With passive monitoring, if I have someone else walk into a room, like how do I know if that's the resident or if that's the cleaning staff who's coming in while the resident's out? And so those are things that are starting to get figured out through things like biometric fingerprints and pieces like that. But ultimately, I think what we're trying to figure out is how do we use this information in the most effective way possible? There's a ton of information coming in, and to put all of that raw information in front of a clinician, it's too much to take on. And so how are people using that information, and how are startups or other groups presenting that information in a way that it can easily be consumed and can focus on action-oriented? So I'm only going to give you the information that shows that there was some change in condition for this resident or something's outside of normal that I think you should respond to, instead of giving you everything and expecting you to make sense out of it. I think eventually we're going to see things get to the point of like diagnosis of, hey, this information is telling us that this person is most likely has a bladder infection or something else is going on with them, but we're not quite there yet. But I think we're going to see a shift towards that as people get more and more comfortable with these technologies.
Yeah, thank you. We got one last question here. I think
Sure.
we're going to try to squeeze it in here. Can you talk a little bit about the future of integration? How we see, because all this tech's coming at us, right?
Yep.
And so can you talk a little bit about that future of what you anticipate, we're gonna see kind of come our way in the next couple of years in the long-term care space?
Yeah, I mean, I think that, where we are today is that there's a lot of startups that are out there that are creating, custom solutions. And what we see time and time again is, we have a dashboard or we have a mobile app. We have a new way or a separate way to show you this information. Unfortunately, that's the way it has to happen, because early as a startup, you're not going to have the integration with all these other systems. But I think what we're going to see is we're going to see integration of information become a new focus. And I don't necessarily know where that information is going to integrate to. So it could be into the EMR, it can be into the medical record, it could be using nurse call systems as an integration point. But eventually what you're going to see is this integration engine happen of taking all of these disparate systems and bringing that information into a single place. And so taking information from your wearables and taking information from your HVAC and air quality system and taking information from these passive sensors and bringing them all together in a single place where I can see them all in a single glance. I can know what's happening, and I don't have to hunt and peck to find the information I'm going after. And so that's going to take a little time to build out. But I think that's certainly the goal, is to get away from, having to go to 5 different places to understand what's happening to a resident, and turn that into, here's my one place where I get my information. I start my day there, I end my day there, and that's what drives a lot of my actions throughout the day.
Mm-hmm. Mm-hmm. Very cool. Good. Justin, I think I'll stop there. Thank you so much. I really appreciate it. Great information. I appreciate the updates, especially the toilet stuff, all that wastewater epidemiology.
Always.
Technology and that science behind all that's really fascinating. And I think, I hope that we're going to continue to see more of that come our way quickly.
Absolutely. Yep. Thanks,
Right.
Liz.
Thanks, Justin. All right. So we've reached the point in our time together here today that we're going to move into our breakout sessions. And so, as I mentioned earlier, we're really hoping that you'll be able to join us for these. When you look at the screen where you logged in today, there are buttons. If you scroll down a little bit just below the video area, there are a couple buttons there. You can pick one and decide, which breakout session you want to go into, either the topic around infection prevention, or there's another breakout around technology innovation. Feel free to go back and forth between the two. You don't have to stay in the one for the whole time. But if you want to pop out there for a little bit, and we're just going to talk, we'll get a chance to see and hear from everybody, and get a chance to see each other a little bit as well. So We'll come back together then about, about 12:45, 12:50. We'll see how the conversations are going. And we'll come back for some closing comments then and wrap up the rest of the day. So off we go. All right. Hi, everyone. Welcome back. Hopefully we got everybody coming back in. Hope you all had gosh, those conversations always just go way too fast. It was so nice to see some of your faces and hear your voices, and just really looking forward to being able to see all of you again next year. So save the date. We've already picked the date for next year, July 12th through the 13th. And we are planning an in-person event for next year. So please, I hope you will be able to join us. We'll be hosting our leadership conference, our educational conference, and we'll also be returning to our live Spark Collective, which is for those who are new to the conference this year. The Spark Collective is an opportunity to be able to meet with startup companies, our tech and engineer designers, and to be able to see things that are in early stage development and be able to provide feedback to the developers early on. And so it's always a lot of fun, and I'm anxious to see what we've got ready to get some feedback on for next year. So I hope you'll all be able to join us live. Just a couple more quick thoughts. For those of you that are planning to attend Argentum, please let me know if you'd like to get together. The Senior Living Clinical Collaborative, anybody who's there, we are going to plan to get together for breakfast or a meal. So just send me a note and let me know. Same is true with ACA and Leading Age. And so if you are planning to attend either of those, please let me know. I would love to be able to see you as well. Just a final thank you, and just a reminder that you'll be getting an email with a survey for this event. Once you fill that out, we'll send you the certificate, and then we'll also, if you have any questions at all, please make sure to give us, send us a note, send us an email, and we'd love to have your feedback as well. In that same email, I'd like to thank those of you already on a somewhat personal and professional note, those of you that have been so gracious in filling out the survey for my doctoral research on future technology priorities of chief nursing officers. So thank you for that. And if you're, we'll send the link out with the email later today as well. If you haven't filled that out yet and you'd still be interested in providing some feedback, I'm going to keep that open until the end of the week as well. So thank you so much to everyone who joined us today. We're going to wrap up just a little bit early, which I know no one is ever sad about that, and give you a few minutes back before maybe your next meeting starts. So thank you for joining us, and I hope you have a great rest of the day, and I'll look forward to seeing you soon. Take care.